Hello, welcome to newborn assessment. So the newborn period. The newborn period is generally referred to as the first 28 days of the infant's life. Nursing goals during this time are to promote the physical and well-being and safety of the neonate and to assist in the establishment of well-functioning family unit. You usually can meet these goals by providing comprehensive newborn care. We initiate and maintain safety practices, teaching parents how to care for their new baby, and supporting and encouraging their efforts. The transition to extrauterine life is a dramatic one for the infant, and so we need numerous physiological adaptations take place in that newborn's body. The newborn is prepared for these changes by the events of normal labor and vaginal delivery. Although these tasks are dramatic and complex, most infants transition to extrauterine life smoothly, but I want you to remember that close observation is required to identify any problems that may occur. During delivery, contractions cause gradual decreased fetal oxygen and pH and increased carbon dioxide during labor. Movement through the birth canal squeezes the chest and thereby removes excess lung fluid. Delivery into the cooler environment and sudden expansion of the chest help stimulate those first breaths. So respirations. Before delivery, the mother's body assumes the role of gas exchange from that fetus via that placental fetal circulation. After birth, though, the newborn must perform this task via breathing. For a smoother transition to occur, the following must happen. Respiratory movements are initiated. Entry of air overcomes opposing forces so that the lungs can expand. Residual air remains in the lungs at the end of expiration to avoid lung collapse. Blood flow to the lungs increase and cardiac output is redistributed. It has been well documented that fetuses make movements that stimulate breathing in utero. Once delivery occurs, though, the infant should take his or her first breath within a few seconds. It has also been theorized that the first breath is stimulated by the temperature change into the cooler environment of the delivery room, acid-base changes that occur through the process of labor, and the stimulation of touching and rubbing that occurs at birth. When birth occurs, though, 4 factors combine to stimulate the respiratory center in the medulla. So that would be the chemical, mechanical, thermal, and sensory. So the sensory factors include handling by the provider when the baby first comes out, drying of the nurse, even the lights, smells, and even sounds. Chemical factors, though, are essential for the initiation of the breathing itself. So during labor, decreased levels of oxygen and increased level of carbon dioxide seem to have a cumulative effect that is involved in the initiation of breathing. Clamping the cord may also contribute to the start of the respiration. Prostaglandins are known to inhibit breathing, and clamping of the cord results in a drop in the level of those prostaglandins. Some mechanical factors are necessary to initiate respirations. As the infant passes through the birth canal, the chest is compressed. With birth, the chest is relaxed, which allows the negative interthoracic pressure that encourages air to flow into the lungs. The profound change in temperature between intrauterine and extrauterine life stimulates receptors in the skin to communicate receptors in the medulla. This also contributes to the initiation of that first breath. There is a video, and you have it in your other PowerPoint presentation. I do encourage you to watch that on your own time. So question. Once delivery occurs, the infant should take his or her first breath within a few seconds. This breath is stimulated by A, warm environment of the delivery room, B, touching and rubbing by the healthcare team, C, suctioning, D, spanking. The correct answer is B, touching and rubbing by the healthcare team. The rationale is once delivery occurs, the infant should take his or her first breath within a few seconds. It has been theorized that the first breath is stimulated by the temperature change into the cooler environment of the delivery room, acid-base changes that occur through the process of labor, and the stimulation of touching and rubbing that occurs at birth. So circulation. Cardiovascular changes that causes the foramen ovale to close at birth are the direct result of increased pressure in the left atrium. With the increase in blood flow to the left atrium from the lungs, the pressure is increased, and the foramen ovale is functionally closed. The pressure in that right atrium decreases at birth. It is higher during fetal life. The following 5 changes must occur to make the switch from fetal to mature circulation. So first we have the closure of the foramen ovale. 2, the closure of the ductus arteriosus. 3, closure of the ductus venosus. 4, decreased pulmonary vascular resistance. 5, increased aortic blood pressure. So these changes are all usually complete by the first day or 2 of life. Newborn assessment. So this is like your first hour. The initial assessment of the newborn is completed within the first few minutes of birth. The assessment usually occurs under the infant warmer. As the baby's born, we take them over to the warmer. This is when we're doing some of the APGAR scoring. The APGAR score is an essential part of the initial assessment and is performed at 1 and 5 minutes post-birth. An APGAR score of 10 means a baby is the best possible condition, while a score of 3 or less often means a baby needs immediate attention and care. So to give you an idea, most babies receive a score between 8 and 10. So obviously, as you're doing your assessment, if your heart rate is greater than 100, you get 1 point, or 2 points, excuse me. If it's less than 100, you get 1 point. You're looking at your respirations. If they're good and vigorous, they get 2 points. If it's weak, you get 1. Muscle tone, reflex irritability, and even skin color. So this skin color is a lot of times where they will lose a little bit of points on, because a lot of times babies will come out with that acrocyanosis. So a lot of times you'll see a baby with like, an APGAR score of 9, and most often they lose a point for their skin color. So the newborn assessment continued. I want you all to know that even though these babies are so cute and precious, gloves are to be worn to protect you at all times until that amniotic fluid and everything is cleaned off from the newborn. The nurse will be looking at skin color, alertness, cry, head size, and other features. The parent's presence actively involves them in the child's care and gives the nurse a chance to observe those one-on-one interactions between the family. The WBC count is high the first day after birth and then declines rapidly. Some medications that we're going to give them. The first one that's usually given is the vitamin K. This is to prevent hemorrhagic disease of the newborn. Vitamin K is administered shortly after birth to the infant. It is not initially vitamin K is not initially synthesized because of that sterile bowel at birth. Vitamin K cannot be synthesized until food is introduced into the bowel, so it is necessary to activate those blood clotting factors within that infant, so we have to give them that vitamin K. Bacteria that synthesizes vitamin K are not present in that newborn's intestinal tract, so vitamin K is provided because the newborn does not have the intestinal flora to produce the vitamin for the first week. So vitamin K is not produced in the intestinal tract of the newborn until after microorganisms are introduced. So by day 8, usually, normal newborns are able to produce their own vitamin K. We also give hepatitis B is recommended for all infants. Hepatitis B vaccine should be given in the vastus lataris muscle. Another one that we do is eye prophylaxis. This is the purpose is to prevent gonorrheal and chlamydial infections of the infant's eye potentially acquired from that birthing canal. So it's really a prophylactic that we give them. We also look at the Ballard scale. The Ballard scale, or you'll hear it as the Ballard score, is commonly used technique of gestational age assessment. It assigns a score to various criteria, and then the sum of all of the scores, which is then added up, and it should actually present in the gestational age of the baby. So, example, term infants typically have a flexed posture. Abundant lingual usually is seen in preterm infants. Smooth pink skin with visible veins is also seen on a preterm infant. And a lot of times you'll maybe see like that faint red marks are usually seen on those preterms also. So you just give them a score, you add it all up, and it should equal out to their gestational age. So some newborn assessment essentials. Lung sounds on the baby should be taken anterior and posterior, should be auscultated on both of those. Normal respirations in the newborn are usually 30 to 60 breaths per minute. Signs and symptoms of respiratory distress, though, in newborns. So some of those things that are definitely need to be reported are like nasal flaring, retractions, grunting or sighing. And a lot of times you'll hear parents that'll be like, oh, they're making a sound. And obviously that's a lot of times that grunting. And we want to make sure that we report that because that is not a good respiratory exchange. Seesaw respirations is another one. Tachypnea. Any of those above findings must be reported to the pediatrician or infant's care provider immediately. Heart rate. The average infant heart rate while awake is, and we talked about this, is about that 120 to 160 beats per minute. The newborn's heart rate may be about 85 to 100 beats while sleeping. So we got to kind of take that into consideration. And I know on here it says 100 and 160 beats per minute, and that's what we will go off of. But I do know, I've talked to you about this before, there's kind of a discrepancy between your ATI book and your actual textbook. And we will go with 100 to 160 beats per minute. The heart rate, though, of 150 to 180 beats per minute is typically when the infant cries. So you got to take all those things into consideration when you're actually taking those vitals. Heart murmurs during those first few days of life have no really significance at this point. An irregular heart rate past the first few hours should be evaluated further. Persistent tachycardia may indicate like respiratory distress syndrome, so we want to make sure that we're reporting those things. And bradycardia may be a sign of congenital heart blockage. So we want to make sure when we are, that we're listening for a full minute and we're listening and counting how many beats per minute they are at each time we are doing an assessment. You can see here too, like your temperature, 98 to 99.4 degrees. Your blood pressure, you'll want to know all these, 60 to 80 systolic and 40 to 50 diastolic. You want to know what is normal so you can know what's not normal. Measurements, you're going to take a length, a weight. You're going to also look at the chest and head circumferences. You're going to look at the infant's posture, their muscle tone, their alertness, and just their overall appearance. And you want to make sure you're looking at that mother and father's interaction with the baby. You're also going to look at skin color and the overall size, shape, and proportion of the infant's body. And you're going to look at the infant's cry. Do they have that strong cry, or is it weak, high-pitched, any of those different things. And then we want to make sure that we have the patency of the anus. So we'll gently insert a thermometer into the anus to check for patency there. So physical assessment. You're going to take those vital times to be checked on an admission, birth, and every 30 minutes times 2 hours, every hour times 2, and then every 8 hours. The weight should be checked daily at the same time every day. We want to inspect the umbilical cord. We want to make sure that it has the correct number of vessels. We want to look at the pain scale. We want to look at some lab tests. That's hemoglobin, hematocrit. We want to make sure we're looking at their blood glucose. their metabolic screening, and then also their bilirubin. So temperature. The newborn's temperature is greatly affected by the change in the environmental temperature that it's in. Shivering as a mechanism of heat production is not developed in the newborn. So therefore, the newborn produces heat primarily by non-shivering thermogenesis. The newborn infant relies on thermogenesis by what they call brown fat or brown adipose tissue. The heat produced by the metabolic activity in brown fat helps to warm the newborn. Reserves of brown fat are usually present for several weeks after birth, but are rapidly depleted in the infant if the infant is in cold stress. This process is unique to the newborn. Maintaining the temperature of the newborn is essential to decreasing the risk of respiratory distress. So obviously right there, what it's telling us is if our infant is cool and if the brown fat's not able to keep its temperature up, it can automatically send those infants into respiratory distress. Normal temperature promotes normal oxygen requirements, and the hypothermic cold stressed infant will have an increased oxygen consumption need, resulting in an increased oxygen need. The cold stressed infant may present with signs of respiratory distress and cardiac depression. So it's very important that we keep those infants wrapped in blankets and check their temperatures and things like that. Cold stress is a loss of heat must be controlled to protect the infant from metabolic and physiological effects of cold stress. And that is primary reason for placing a newborn under that radiant heat warmer or skin to skin on that mother's chest. Cold stress results in an increased respiratory rate and vasoconstriction. The newborn's flexed position guards against heat loss because it reduces the amount of body surface exposed to the environment. Babies lose heat by convection, so you're going to need to know these different ones and what they are, okay? So convection is losing heat from the body due to cooler air. It is important to keep the infant wrapped, and heat loss by convection also occurs when drafts, like from open doors or air currents created by people moving around, can also make that infant's temperature drop. If the heat loss is caused by placing the baby near cold surfaces of equipment, it is referred to as radiation heat loss. Conduction is the loss of heat from the body surface to cooler surfaces, not air, in direct contact with the newborn. It occurs when the baby comes in contact with cold objects or surfaces. So like if you're going to lay them on a cold countertop or those type of things. Evaporation is the loss of heat that occurs when a liquid is converted into a vapor. The newborn heat loss by evaporation occurs as a result of vaporization of moisture from the skin. So as nurses, we can prevent evaporation heat loss in the newborn by drying that baby right after birth and wrapping that baby in a dry blanket. Keeping the head well covered with a cap will prevent further heat loss from the head, and having that mother place the infant on that skin to skin, or what they consider that kangaroo care, should increase the infant's temperature after birth. If your baby does have slightly decreased temperature, it can be treated in the mother's room. This would be an excellent time for parent teaching on how to prevent that cold stress, how to keep your baby, wrapped up, things like that. But that mild temperature instability is an expected deviation from normal during the first days as the infant adapts to external life. So we just need to keep a good eye on that, and I want to make sure that you understand these mechanisms of heat loss and what they are. So the skin, heat loss mechanisms of that newborn, that full-term newborn will have like a cheesy white substance on the skin called vernix caseosa. This covering helps to protect the fetus's skin in the utero. Premature babies often do not have vernix, and post-term infants may only have it in certain areas such as like skin folds. The skin color and turgor should be assessed. We want to note any skin lesions or any discolorations of any sort. We want to make sure we're assessing the skin integrity and check for breaks in the skin from like if we had to do like a scalp electrode or maybe a forceps, anything like that. Skin wrinkling and peeling is common in infants who are post-date. And acrocyanosis or cyanosis of the extremities is a variation of normal during that first 24 hours after birth. So central cyanosis versus acrocyanosis. So acrocyanosis or cyanosis of the extremities is a variation of normal during that first 24 hours after birth. Acrocyanosis, this is normal right after birth. In fact, most newborns have some acrocyanosis for the first few hours of life. This happens because blood and oxygen aren't circulating properly to the hands and feet quite yet. The problem usually goes away as the blood vessels in the baby's hands and feet open up. However, an infant who is dusky and becomes cyanotic when crying is showing poor adaptation to extrauterine life. So we want to make sure we know the difference between acrocyanosis and cyanosis. And when do we need to intervene and when do we not need to intervene? So the newborn skin should be pink with areas of vernix, with or without bruising and abrasions from the birth process. Cyanosis may be normal if it appears A, around the mouth, B, on the extremities, C, all over the body, or D, none of the above. B, on the extremities. Rationale is skin color and turgor should be assessed. Note skin lesions or any other discolorations. We want to assess skin integrity and check for breaks in the skin from the scalp electrodes or abrasions. Skin wrinkling or peeling is common in infants who are post-date, and acrocyanosis or cyanosis of the extremities is a variation of normal in that first 24 hours after birth. So luengo is that fine, downy hair seen on term newborns. It's like a hairy little kind of fuzziness almost, kind of. The milia is distended white glands, which is pretty normal on newborns also. And mottling, these are patchy, irregular colors. And you can kind of see it on the screen here a little bit. You can see it's like a different, like patchy little colors on here. But you'll want to know the terms and what those refer to. Some other skin things is the Mongolian spot. This is a bluish black area of pigmentation that may appear over any part of the exterior surface of the body. It is more commonly noted on the back and buttocks and frequently is seen on infants whose ethnic origins are Mediterranean. We also see it on like Latin Americans, Asians, or African. These spots fade gradually over months and have no clinical significance. So the main thing I want you to know with these is what they are, and as a nurse, what do you have to do with them? So like this one here, this is a normal finding and have no clinical significance. Vascular nevus, this is commonly called the strawberry mark, and it is a type of capillary hemangioma. Nevus flammeus, this is commonly called the port wine stain. It is most frequently found on the face. They call them like stork bites, angel kisses, that type of, you'll hear them referred to as. They may fade over time and they have no clinical significance. The erythema neonatrium, this is a transient newborn rash that resembles flea bites. This is a normal finding that does not require any additional interventions or physician notification. Petechiae or pinpoint hemorrhagic areas acquired during birth may extend over the upper portion of the trunk and face. These lesions are benign if they disappear within 2 days of birth and no new lesions appear. So again, these lesions are benign if they disappear within 2 days of birth or no new lesions appear. They may result from decreased platelet formation or soft tissue injury, like maybe like a cord around the neck at birth, or a breech presentation, vaginal birth, where some of those things are a little more traumatic. So unless they do not dissipate in 2 days, there's no reason to alarm the family. When we're looking at the cranium, the newborn's head is large and heavy. It may appear that the head is too big for the rest of the material protected by, the rest of the body. So it's might look out of proportion. So their head's larger than their body. The bones of the newborn skull are joined by connective tissue that are called sutures. These areas are where the bones have not grown together are called fontanelles or soft spots. In order for that baby's head to move through the birth canal, the skull is able to move with those soft spots due to those two fontanelles. As the head moves through that birth canal, the head will become molded. Additionally, the fontanelles accommodate that rapid growth of the brain during infancy. So let's talk about them a little bit. So the anterior fontanelle. This is a diamond-shaped fontanelle is located at the juncture of the frontal and parietal bones. The anterior fontanelle usually closes within the first 9 months of life. Assessing the anterior fontanelle reveals clues to the infant's condition. The fontanelle should be assessed with the infant in a semi-sitting position. When assessed in this position, a bulging fontanelle indicates increased intracranial pressure, and a sunken fontanelle is indicative of dehydration. It is normal for the fontanelle to bulge slightly when crying or when stooling. You may also be able to palpate the heart rate. So that was the anterior. So now let's talk about the posterior. The posterior fontanelle is formed by the parietal bones and occipital bone in the triangular shape and smaller than the anterior fontanelle. The posterior fontanelle usually closes within the first 1 to 2 months, but may appear closed at birth due to the small size. Cephalohematoma. This is a collection of blood between the skull bone and its coverings, and is known as a cephalohematoma, and it feels like a soft bulge almost. This may occur with a spontaneous vaginal birth as a result of the pressure against the maternal bony pelvis. However, the cephalahematomas can also occur spontaneously. They usually disappear gradually over 2 to 3 weeks, and infants in whom cephalahematomas develop are at increased risk for jaundice. And the reason this is because of the breakdown of the red blood cells within a hematoma. The infants are at greater risk for jaundice, and it can occur after the cephalohematoma birth injuries because the baby's body needs to replace those lost red blood cells. So know that they are more at risk for being jaundice. Caput succedaneum. This is a medical term describing swelling that occurs to the baby's scalp shortly after delivery. During childbirth, especially during that head first deliveries, pressure exerted on a baby's head can damage the scalp, and it can lead to this here, as well as other birth injuries. But that caput is swelling produced on the presenting part of the fetal head during labor. It usually results from a long or difficult labor or a vacuum extraction at delivery. The swollen area can be over a small or large portion of the scalp and overrides the suture lines. The caput is present at birth and generally subsides over the first several days of life. So head and neck. The infant's face should be observed for suture or structure or symmetric movements. The eyes, ears, nose, and mouth should be assessed for symmetry and any other obvious abnormalities. In the normal newborn, the pinna or top of the ear should parallel to the canthus of the eye. Low set ears may indicate chromosomal abnormalities. The neck of the newborn is short and straight with skin folds, and the newborn is unable to support the weight of his or her head due to lack of muscle tone development. The clavicles should be assessed for signs of fracture. The normal clavicle is straight and intact, and any evidence of swelling or a knot or lump on the clavicle or even crepitus on the neck may be indicative of a fracture and must be reported to that physician or nurse practitioner. And just a little fun fact, did you know that the ears and the kidneys form simultaneously in utero? Therefore, an infant with abnormal ears should be assessed for renal function also. Chest. The size and general appearance of the chest should be assessed. The head circumference should exceed the chest circumference by 2 centimeters within that first 18 months. The chest circumference will then match the head circumference and then begin to exceed the head by 5 to 7 centimeters by age 4. So I'm going to repeat that. So the head circumference should exceed the chest circumference by 2 centimeters when they're born. Then within that first 18 months, the chest circumference will match the head circumference and then begin to exceed the head size by 5 to 7 centimeters by age 4 years. Both sides of the chest should expand equally with inspiration. The breast may become engorged in both males and female infants due to hormonal influences from the mother and may last a few weeks after birth. We want to make sure that the presence of any accessory nipples needs to be documented. These extra nipples do not contain any granular tissue and are harmless, but we do need to make sure we document if there is any noted. However, though, widely spaced nipples may be associated with congenital abnormalities such as Down syndrome and need to be further investigated. So question. At birth, the head circumference should be blank than the chest circumference. A larger, B smaller. A larger, and that's what we talked about, that at birth it should be 2 centimeters, the head should be 2 centimeters larger than the chest. Abdomen. The infant's abdomen protrudes slightly and moves with respiration. The umbilical cord stump should be inspected for the presence of 2 arteries and 1 vein. A single umbilical artery can be associated with congenital abnormalities. We want to make sure the cord stump should be kept clean and dry and will begin to dry up within several hours of delivery. The umbilical cord stump generally falls off within 7 to 10 days of birth, and the abdomen is assessed for bowel sounds and gently palpated, checking for softness, tenderness, or presence of masses. The genitals. The genitalia of the newborn should appear normally formed. In the male infant, the foreskin will cover the glands with a slight opening at the tip. The penis should be inspected to see that the urinary meatus is in the correct position at the tip of the penis. The testes should both be descended and palpable in the scrotum. In the female, we want to make sure the labia majora cover the labia minora at term. The clitoris is normally large in the newborn. And a thick white vaginal discharge may be present and can become almost a little bit blood tinged at times. This is related to the withdrawal of the maternal hormones and is normal. It is a normal finding. The discharge generally subsides within a week or so, and the vernix caseosa, that white cheese-like substance, may adhere to the labia. This should not be actively removed, as doing so may irritate that tender tissue in that area. This substance will slowly disappear with subsequent diaper changes and baths, and the anal area is visually to check for the patency and evidence of fissure. Let's talk about circumcision just briefly here. The infant should be observed for urination after the baby is circumcised. We need to make sure that they're urinating properly. Bleeding is common complication after circumcision, so the nurse will check the penis for 12 hours after circumcision to assess and provide appropriate interventions for preventions and treatment of bleeding. There's like a yellow exudate that covered the glans penis in 24 hours after the circumcision. This is part of a normal healing and not an infectious process. The exudate should not be removed. We want to make sure we're cleansing the penis gently with water and putting petroleum jelly around the glands after each diaper change are appropriate. Now I'm going to talk to you about the whole petroleum jelly. It all depends on what your pediatrician orders, and everybody's a little bit different, so I want to make sure you know that. But in all of them, we want to make sure we're cleansing that penis area and keeping that clean. With each diaper change, the penis should be washed off with warm water to remove any urine or feces. And if bleeding occurs, the nurse should apply gentle pressure to the site of the bleeding with a sterile gauze square. And circumcision is painful and must be managed with environmental, non-pharmacologic, or pharmacologic measures, and that's depending on your pediatrician also and what they order. After the procedure, the infant may be fussy for several hours or may be sleepy and difficult to awaken for the feeding. Swaddling and like non-nutritive sucking, whether that be a pacifier or those type of things, or skin-to-skin contact with the mother. And we have found that sucrose also are appropriate non-pharmacologic techniques used to manage pain in those neonates. And we've also seen acetaminophen given to help treat that pain for the infants. But remember, the main thing is that after we are doing the circumcision, we're watching for bleeding and making sure that what is normal and not normal. Elimination. Urination. Urine should be passed within the first 24 hours after birth. Thereafter, minimum urination should correlate with the number of postpartum days. So, for instance, on day 1, we want 1 to 2 wet diapers is acceptable. If you're progressing to 7 to 8 wet diapers by the end of the first week, and that's normal. The urine should be observed for urate crystals, which may occur in the first few weeks of life and indicate that the urine is highly concentrated. These crystals are harmless in that very early postpartum period and should disappear spontaneously prior to discharge. Bowel movements. The passage of that first meconium stool should be noted within the first 24 hours. The normal appearance and frequency of stool should be discussed with the new parents, as stool patterns depend on the method of feeding, and that is very, very true. All newborn stools transition from meconium to transitional stools, which are green in color, before taking on that typical yellow color on usually day 3 or 4. Now, if you're breastfeeding newborns, they may have 6 to 10 small semi-liquid yellow stools by day 4, and after milk production is established. Formula-fed infants may have 1 to 2 bowel movements a day, and the stool is usually more solid and yellow or brown in color. Jaundice. That newborn jaundice occurs when a baby has a high level of bilirubin in the blood. Bilirubin is a yellow substance that the body creates when it replaces old red blood cells. The liver helps break down the substance so it can be removed from the body in the stool. A high level of bilirubin makes a baby's skin and whites of their eyes look yellow, and this is called jaundice. Neonatal jaundice occurs in 60% of newborns. The complication is called cancerious, and it is rare. But the jaundice in the first 24 hours at that persistent past day 7 is cause for medical concern. Parents need to know how to assess for jaundice in their newborn. So if we're seeing that it persists past day 7, many times we might send the infant home at day 2 after birth, but we might bring them in day 3 or 4 for another check to see on what their bilirubin level is at. Kernicterus is a bilirubin-induced brain dysfunction, and can be the side effect, or the result of jaundice if we can't get it fixed. Bilirubin is a highly neurotoxic substance that may become elevated in the serum in a condition known as hyperbilirubinemia. Physiological jaundice. Most newborns have some yellowing of their skin or jaundice, and this is called the physiological jaundice. It is most often noticeable within the baby's 2 to 4 days old. It becomes visible when the serum bilirubin reaches the level of 5 milligrams or greater, which occurs when the baby is approximately 3 days old. So to give you an idea, like a normal finding would be under 5 milligrams. Pathologic jaundice is caused by blood incompatibilities causing excessive destruction of erythrocytes and must be investigated. Breastfeeding, I want you to know, is also associated with an increased incidence of jaundice, and it's caused by insufficient intake of fluids right away, because obviously that when we're waiting for that milk to come in, the baby doesn't get that fluids that it needs to be able to excrete that bilirubin. So what do we do for high bilirubin levels? We will put them under we'll put them under phototherapy. It is the most common treatment for reducing high bilirubin levels that cause jaundice in newborns. In the standard form of phototherapy, the baby lies in a bassinet or enclosed plastic crib. It can even be in like the incubator styles, and is exposed to a type of fluorescent light that is absorbed by the baby's skin. If it's receiving phototherapy for hyperbilirubinemia, shields are placed over the newborn's closed eyes. The infant's eyes must be protected by an opaque mask to prevent overexposure to the light. Eye shields should cover the eyes completely, but do not occlude the nares. So we want to make sure that we can see here it covers their eyes completely, but we want to make sure we do not cover the nose area. Eye shield should, lotions and ointments should not be applied to the infant because they absorb heat and this can cause burns. So we want to make sure their skin is just clean and does not have any lotions or ointments on it. The lights increase in insensible water loss and placing those infants at high risk for fluid loss and dehydration. So therefore, it is very important that the infant be adequately hydrated, and the infant should be turned every 2 hours to expose all body surface to light. So again, they need to make sure that they're turned every 2 hours. And we want to expose as much of the body here as possible that can be in contact with that light. And so obviously too, we want to make sure in this case here that we're checking their temperature so that we have them at the right temp, that we don't have the baby too hot, too cold, anything like that. We want to make sure they're at the right temp and that they have those eye shield covers on and they do not have any lotions or ointments on their body to help prevent any burns. Hips, we want to look for hip dysplasia. They call this the Ortolani maneuver. It is used to detect the presence of hip dysplasia. If we have unequal movements or uneven gluteal skin folds, that gives us an inclination. The physician would need to be notified that the infant has a dislocated hip if you have found anything like that. Just a little cute thing, here you can see the difference. My little cute cartoon here. The reflexes, I'm not going to go through all these. I want you to know them though. Many of them you've had before, but I kind of put them back out here. I want to make sure that you understand what these are because you'll probably be asked these like on an NCLEX style question, and you need to know like what the Moro reflex is or the rooting reflex, things like that. So make sure you look at this before the exam. I want to talk a little bit about SIDS. This is sudden infant death syndrome. It is an unexplained death of an infant younger than 1 year old. SIDS is the leading cause of death in children between 1 month and 1 year old, with most cases occurring when babies are between 2 months and 4 months old. Although healthcare professionals don't know the causes of SIDS necessarily, there are always ways to reduce the risk. And these always include placing babies on their back to sleep, even for short naps. The tummy time is for when babies are awake and someone is watching them. Otherwise, they should be placed on their back. We want to make sure they're using a firm sleep surface, such as a crib mattress covered with a fitted sheet. We want to keep soft objects and loose bedding away from the sleep area. Making sure babies don't get too hot. Keep the room at a comfortable temperature for an adult. So making sure that those babies are just at a comfortable temperature. So again, back to sleep. So some parent caregiver instructions. The infant should be laid down to sleep on his or her back for better breathing and to prevent sudden infant death syndrome. Infants should always be placed back to sleep and allowed tummy time to play, but only when awake. Infants are vulnerable to respiratory infections, so infected people must be kept away. Secondhand smoke can damage their lungs. We also want them to know infants can suffocate in loose bedding and furniture can trap them. We also want to talk about the mouth should be suctioned first to prevent the infant from inhaling like any secretions by gasping at the nares. Because like when you go to suction their nares, they kind of gasp. So we always want to make sure we suction the oral first and then the nares. We want to make sure after compression of the bulb, it should be inserted into one side of the mouth. If the bulb is inserted into the center of the mouth, the gag reflex is likely to be initiated. When the infant's cry no longer sounds as though it is through the mucus or a bubble, suctioning can be stopped. The bulb syringe should remain in the crib so that it's easily accessible if needed again, because this is so many times I've heard parents say, if I wouldn't have had that bulb syringe, I don't know that my baby would be here. And it's just clearing those excretions from those airways. A measure taken by many facilities is to ban both the mother and the baby with matching identification bracelets and ban the infant with an electronic device that will alarm the infant or alarm the nurses if the infant is removed from that maternity unit. It is impossible for one nurse to be on call for one mother and baby for the entire shift, so parents need to be able to identify the nurse who are working on the unit also. So we want to make sure they're well identified too. Infants should always be transported in their bassinets in the hospital for both safety and security reasons. All maternity unit nursing staff should have unique identification bracelets in comparison with the rest of the hospital. It's just for protection of the baby and making sure that the baby is always safe on the maternal care unit. All right, so that is the end of the lecture. And so again, this was the newborn assessment.